Welcome to Medical Matters Weekly with Dr. Trey Dobson, presented by Southwestern Vermont Healthcare and Catamount Access Television.
Well, welcome everybody.
Welcome.
Thank you for joining us on this February 2nd, 2022, as it's been pointed out to me several times. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth-Hitchcock Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. My guest today is certified hand therapist Michaelia St. Jacques. Did I say that right, Mick?
You did. Yep.
So Mick, she goes by Mick, and she has lots of letters after her name, and I'm going to read those, and then she can explain what they are. OTR/L, CWCE, and CHT. So what do those mean, Mick?
Sure. I'm an occupational therapist. I am registered with the National Board of Occupational Therapy. I'm licensed in the state of Vermont. And then the next one I think is CWCE. So that's a Certified Work Capacity Evaluator. That means that I am able to help determine somebody's ability to go back to work after sustaining an injury, if they've had some rehab. And then I newly in the last year have become a certified hand therapist, which is the CHT.
That's awesome. Congratulations on that accomplishment. And we'll talk more about that. Just a little bit about Mick's background. She received her bachelor's degree in biology from MCLA down the road, master's in occupational therapy from the Sage Colleges in New York. And then, as she mentioned, she earned her CHT, Certified Hand Therapist credential from the Hand Therapy Certification Commission last year. And she is a member of the National Board of Certified Occupational Therapists and many other organizations. So we're so excited to have you here. Let's talk a little bit about just your background before we get into all of your handwork. Tell us a little bit about where you're from and just what you've experienced in life.
Yeah, so I grew up in Massachusetts. I still live in Massachusetts. I live in a tiny, tiny town called Monroe, Mass. We actually just moved into our house about a year ago that my husband built for me and my daughter. So we live up in Monroe. I've been here at the hospital since I graduated from grad school, which was in 2013. So I'm coming up and almost on my 10th year already. I actually was a graduate student here, did my field work here, and then loved it so much, took a per diem job to get into the hospital system, and then kind of worked my way up and built a full-time position and have been here ever since.
I want to go back to your husband building your house.
Yeah.
I mean, you're an occupational therapist. Did you just stand over him and tell him what he was doing correctly and incorrectly?
Yeah, a little bit. So he's a machinist by trade, and works for an awesome, cool little machine shop in North Adams, Mass. And when we got married, his dad goes, "Oh, here's 10 acres of land." And I said, "Oh, this is great, but it's in the middle of nowhere." And they said, "It's okay. We'll build you a house and you'll love it." And so over the course of probably 5 or 7 years, he cleared all the property. He took a whole bunch of classes to figure out what to do, and he built our house.
Wow,
yeah.
That is just a renaissance, man. That is so cool.
It is.
All right, and so then what got you into occupational therapy? And then actually, first off, give a little description of what occupational therapy is for our listeners.
Yeah, so occupational therapy is a really cool, holistic discipline that can be found in so many different settings. So to become an occupational therapist, usually you need a master's degree. You take a lot of courses in just general science, how the body works, how the brain works, and then to put it all together and how to help people recover those aspects after some sort of injury. So some OTs work in the community, in our schools, preschools, elementary schools. Some work in the mental health field, so they might work with somebody with addiction or depression or anxiety. And then I have always worked in a medical setting, which is how I ended up here at the hospital. So even in our hospital, our OTs look very different depending on where they work. So you can work with patients after they've had a stroke or an orthopedic surgery, a hip replacement, a knee replacement. After you have COVID and you're just really weak, you might see an OT, all the way to seeing an OT in our outpatient setting. We work everything from kind of how your brain works, from executive functioning, can you do math, can you pay bills, to how your upper extremities work. I would say our facility here There's three of us actually who work at Outpatient. We all really focus on kind of how the arms work. So that would be kind of it's such a huge umbrella. It's a really cool field because if you ever kind of want to go work somewhere else or do something else or kind of dabble in an area, you can do that.
Yeah, I think a lot of us outside of hospital systems have come across occupational therapists really from, knowing that our kids in schools had seen an occupational therapist. And so what does an occupational therapist do in the school system?
Yeah, so actually, we at our hospital have two occupational therapists who work for us per diem on the weekends. So I get to talk with them all of the time. And then we have another OT who helps in some of our schools actually as well. So OTs in the school can work on some sensory type things. If your kiddos' clothes don't feel right for them, they seem like they're high energy and you need to get that out, or they seem like they might not be as strong as their peers. There's also a large handwriting and fine motor component for OTs in schools. So they might work on, can they write their name? Can they use their scissors? Can they color within the lines? Mm-hmm. Yeah.
So we'll get more into that. Let me go back to the initial question I asked you, and then I kind of jumped over and asked about occupational therapy. How did you get involved in occupational therapy, or just tell us a little bit about your path and your interests?
Yeah, so my mom is an RN, registered nurse. She actually has her doctorate in nursing. So I was kind of always thinking healthcare, kind of thought about nursing. My mom worked night shift with nursing. And so I kind of saw the stressors of that. And I said, okay, I want healthcare, but maybe I want a little bit more flexibility in my career, I'll be honest. So I started dabbling in maybe some more specialty areas. I actually did 2 entire years for speech therapy at UMass Amherst, and then realized that wasn't quite the field I went into. So I ended up going into just straight biology and said, I'm just going to get my biology out of the way and then I'll figure it out. Then I did some observations. I ended up observing a couple of different OTs in the school setting, in an outpatient in a nursing home. I also looked at some physician assistant positions and things. And then I hooked up with an OT at an outpatient setting, and they were treating pretty severe hand injuries. And I said, oh, that's what I'm going to do that. So
then I'm going to ask this question that I know you get all the time. I'm sure we did not talk about this ahead of time, but what is the difference between a physical therapist and an occupational therapist?
So I knew when I was coming on this show that it would somehow come up. That is the hardest question ever to explain, because we work very closely together. And so the lines kind of get blurred and they meld together. Degree-wise, very different. The physical therapists have a doctorate in physical therapy, typically. And their coursework really goes from head to toe. More into the muscle and bone structure and all of that aspect of the body. OT initially was founded in mental health and they kind of worked their way into the physical medicine rehab way, which is kind of the pathway I took as well. It's a hard one. Depending on where you are in the state, even in the country, you might end up seeing an OT or a PT for a specific injury. It could go either way.
Okay. And I know here at SVMC, we have both OT and PT, and you all work together, sometimes on the same patients.
Exactly. Yep.
Yeah, that's great. So tell me a little bit about the specific hand therapy and what you do, and maybe even what the training involves.
Yeah, so in order to become a certified hand therapist, you have to have 4,000 hours of clinical experience with hands. And then there's a pretty comprehensive test you have to take in order to do that. Hand therapy is a very specialized area. So when you start to think about the hand and how many muscles and bones and tendons and arteries and all, everything that's in there, it's pretty complicated. So the goal with a certified hand therapist is somebody who has exquisitely studied kind of the shoulder all the way down to your fingertips, which is what I did.
And that's what you do. And actually at SVMC, more recently, we've had a hand surgeon join, and Dr. David Beltry. And I'm sure the two of you share patients on a daily basis.
Yeah, so Dr. Beltry actually pushed me a little bit in the kindest of ways and said, I need a certified hand therapist and you sound like you would be a good fit. Have you thought about taking the test? And I said, well, it's been on my to-do list. I need some more experience and I really need a doctor to help mentor me with that. And he says, I'll do it. Let's get this done. You gotta take the test. So with his kind pushing, I decided to move forward with it. I actually work in clinic with him every Tuesday. So typically his post-op patients we see together. So on every Tuesday, he has, 8 or so patients and he sees them and then we start their therapy right away. So we are in very close communication about our patients.
That's great. And that kind of explains my next question in part, but how are patients referred to you typically? So you have that mechanism when you're working right alongside Dr. Beltry, but what other ways?
Yeah. So any kind of, any physician, nurse practitioner, or physician assistant can write an order for, usually it's just for straight occupational therapy. And then they'll write if they think they need a certified hand therapist on top of that. I will say that our OT team here is very close and very well educated. So typically we tend to share a lot of our patients. And then if anything complicated comes through, I might do a little extra research on what we should do with them. So I get a lot of referrals from our hospital source, but also from outside of the community. If a patient has gone to see a specialist up at Dartmouth or, over in New York or at Mass, and they're looking for a certified hand therapist, if they search for me, they usually get a direct referral that'll say Mick right on it.
That's great. And so then you see these patients and how, on average, I know that all cases are different. How many times are you seeing them? Is it a one-time encounter or does it go on for months? What is the usual pattern you see?
Yeah, it really depends on the surgery. In the best case scenario, somebody just needs to come see me one time and I teach them everything that they need to do at home and then they kind of independently do it. Certainly patients love that because it's less time commitment and, financially easier on them. I would say on average, I usually see my patients probably one time a week for 6 to 8 weeks, I would say is probably average, especially if it's a patient who's post-operative. Meaning that they had more involved and I might see them a little bit more.
Gotcha. And you mentioned financial, so I'll jump into that one real quick. Is this typically covered by insurance, the work that you do?
Yeah, it is. Occupational therapy is usually covered. We take, as you know, here at the hospital, most insurances. So easy ones rattling off the top of my head: Medicare, Medicaid, OneCare, Blue Cross Blue Shield, any of those, workers' comp, all typically have some level of OT coverage.
Right. And then for the audience there who may be wondering a bit, who don't have experience, there's a good reason that the insurance covers occupational therapy because the outcomes are better when you have, particularly with hand. Boy, hand is so important for not only for work. We think about hand in most occupations being almost critical, but also just in life. And I can tell you personally, just even in my 15 years of emergency medicine, those individuals who have followed through with an OT or a PT program, but we're talking about OT right now, almost invariably have a better outcome than those that for some reason don't follow with the program.
Yeah, definitely.
So let's talk a little bit about the challenges that you face in your day-to-day work, or maybe you could give some examples of difficult situations.
Oh boy. I'll be honest, the rehab world is pretty relaxed. We're a chill group of people. We have music going and we have a plan. So in general, my work day is pretty easy going, and it's very enjoyable. I would say some of the things that can be difficult is knowing what the doctor wants. And that's my job to figure it out. So if I get an order from a physician that I'm not familiar with, I've never worked with them, or I've never seen a surgery they do, it's up to me to figure out what they want me to do. So some phone calls, emails, hunting down that surgeon and saying, what do you want me to do with this patient, so that I can make sure then that the patient's doing everything that they can to get themselves to their goals. Generally pretty.
Yeah, actually remind me to. Yeah, I love how you said that OTs and PTs are pretty chill. You just are an advertisement for those interested in going into healthcare. Emergency medicines are pretty chill position too. I'll just throw that out there, but maybe not quite as much. We don't usually have music going. I wish we did. Let me just go back and just try to give the audience who may not have experience just an idea. So just walk me through a typical patient experience. They have surgery, for example. Why do they need to see the occupational therapist? What do you do for them? And I think that'll give a good illustration.
Sure. I will give you my favorite scenario because it kind of typically affects our middle-aged male population who have worked with their hands forever. And, I came from a blue collar family, so I really like that population. So there's something called Dupuytren's, which is people start to get kind of cords on their fingers and it pulls them down and they can't open it. So unfortunately, that's a progressive condition, and there is nothing conservatively, meaning no exercises, no stretching or anything we can do to make it go away. You do need surgery for that one usually. So patient goes and has surgery. Dr. Beltry does his procedure, and then they follow up with me. At that first visit, I check out their wound. I see what it looks like. I take some measurements to see, were we able to get those fingers all the way straight, or are we still curled in a little bit? And with those measurements, I establish goals with the patient. What do you need to get back to? Oh, I need to use a chop saw. I want to ride my motorcycle. I like to row. We determine all of our goals, and then I start to give you exercises. We also, for a lot of hand surgeries, we make splints, also called orthosis. It's this really cool material. I don't know if you've ever seen one, Trey. I actually just made one in the hospital, and all the nurses were super impressed. They had never seen it. So it's a low temperature thermoplast that we put in a hot water, and then we mold it, and then we attach Velcro and straps, and we can put it in lots of different positions depending on what we need it to do, but it's kind of like a removable cast. So with somebody with a hand surgery, usually that's key. So that Dupuytren's, they probably get an orthosis. And then we'd set up a plan of care. So I am huge on patient responsibility. So I think that I will teach you what to do. You're going to do it at home, and then you're going to come back and see me, and I'm going to give you more stuff to do, and I'm going to take away some stuff to do. So then I might see you once a week for a couple weeks. Call, check in, how you doing? You need to come back and see me. Oh no, I'm good. I'm back riding my motorcycle. I'll call you if I need you. And then, usually they don't call me, but sometimes 6 months down the road, they're like, I can ride my motorcycle, but my hand's not as strong. What should I do? And then they might come back and see me.
That was a great visual. I can see that through. I do know orthosis. I actually send people, especially if they have things like de Quervain's, tenosynovitis. It's much better than just an aftermarket splint that's designed to fit everybody under the sun. I like that specific fit that you can provide to them. Through molding it just to that person. So that's great. So tell us a little bit about the past couple of years and how the pandemic may or may not have affected your work.
It affected outpatient rehab, quite a bit in the beginning of the pandemic. Just like everyone else, we weren't sure exactly what we should do. Should we have our patients come in? Should we do some telehealth? There's some people that we just needed to see in person. I had to see the wound. I had to take the stitches out. I had to make a splint. So, we saw some of those people. I did a lot of telehealth where we saw people through a one-to-one on the screen like this. That was probably my favorite thing that came out of COVID. We live in rural Vermont, and people don't always want to drive an hour to see us. So that telehealth aspect of being able to do it over the computer was really cool. So that was a positive for us. We saw a shift of people weren't getting as many procedures or surgeries done. So we were utilized in some other areas, whether it was, helping out our coworkers in the hospital or helping out with some more administrative stuff. For a little bit there, we were kind of just helping in where we could. And then now I would say, since things are lightening up a little bit, we're full bore. I mean, everyone's catching up. They're like, oh, I got to get this hand done. And, an interesting thing too, while I'm talking about that, is a lot of people picked up new hobbies. And weren't fully prepared for them. So now people are coming in and they're like, I started working out all the time and now my wrist hurts like this. And, we look at their routine, we say, well, you're not quite doing it right. Let's refine that. Or somebody new started working from home all the time. People were used to being in office and now they're at home working on their laptop. So we got a lot of work injuries following COVID, but it was an interesting thing, a little bit slow, then a little bit of helping everywhere. And now it's super busy.
Are you doing any telehealth visits anymore, telemedicine visits, or is it mostly gone back to in-person?
We are mostly back in person. When somebody might not be able to come in because somebody in their house has COVID or something and they want to continue with their therapy, we offer telehealth still because we are able to do that. But I would say 95% is back into in-person.
Yeah, that's great. We'll do a whole show on it here sometime, but there are so many advantages of telemedicine, but not quite to the level that that we would anticipate, because there are so many advantages to in-person interaction. And, I was talking to someone recently and they said, yeah, I think that telemedicine was really cool, but I actually want to leave my house and see you in person sometimes. And I think that's just, that's just human nature. It's society behavior. And in inner city, there can be different reasons to do telemedicine, and rural areas, different reasons. But I'm glad that that you're still offering it to those that it makes sense. Yep. And then, of course, seeing people in person that want to be seen. So let's finish up here. Let me just ask you two things. Just tell us a little bit about what your personal goals are over the next year or two, and then any professional goals you may have.
Yeah, so my biggest professional goal was to get my CHT. And so for the first time, I'm not studying or preparing for anything. With that, though, there's still, day-to-day preparations of what do I want to do for my patients, always kind of studying in the background. But to be honest, is just to enjoy my certification and working with Dr. Beltry and kind of refining what I like to do with all of those patients. So just kind of, living the hand therapy world is, I guess, my biggest professional goal right now. Personally, now that I'm not studying, I would like to work out some more and be outside a bit more. And now that I have time to kind of get back into hiking and not so much studying, that's what I would like to do.
That's great. Get outside, and also maybe you could put an addition on the house now that it's complete, and put a gym and a sauna and some other things over there.
I could think of a few.
That's great. So, as we close here and people are learning about occupational therapy, if they thought that maybe they need something they benefit, what's the best way for them to get to you? Is that going through their doctor and getting a referral? Yeah,
definitely. So the first thing is the SVMC website does have some information about what we offer, and that has our contact information. Our front desk is super knowledgeable and can answer so many questions if you're just not sure. And then, yes, your doctor would need to write an order and we would get you scheduled.
That's great. Thank you so much, Mick, for coming on the show. This is Mick St. Jakes from SVMC Outpatient Rehabilitation. I'm also going to thank Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, and Ashley Jowett from Southwestern Vermont Healthcare. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we will see you next week.